Hello, and thank you for your interest in mobilizing med management to prepare for a new environments of care. My name is Perry Flowers with Beck & Dickinson. I serve the organization as Vice President of Medical Affairs, bringing 29 years of healthcare experience as I lead Enterprise Medication Management Team with the Med Management Solutions Group of BD. It is my honor to introduce two distinguished colleagues and fellow presenters, Kelly Ropke and Donya Dumitriu. Kelly, a nurse, researcher, and author, leads thought leadership effort for medical affairs. Donya, a pharmacist, researcher, and also an author, leads critical areas of enterprise medication management. Both Kelly and Donya are experienced health system leaders with both general operations as well as specialty clinical practices. Welcome. Before Kelly, Donya, and I begin this presentation, first, permit me to send a heartfelt thank you to all those caregivers, frontline clinicians, first responders who are caring for the many COVID or presumptive COVID positive patients. To those in epicenters, I recognize every health system answered the call to care. Thank you. Today's agenda for mobilizing med management to prepare for new environments of care will focus on three key areas: new environments of care, mitigation steps for cross-contamination, new resourcing efforts to protect caregivers. A quick disclaimer: the information contained in this presentation is based on published guidelines as well as internal clinical expertise. The implementation of this information is at the sole discretion of the hospital or health system based on established policies and procedures. Kelly, the news has reported several metro areas as well as health systems' efforts to address the COVID surge of patients. Would you speak about several of these new care unit scenarios?
Sure, thank you, Perry. When we start talking as healthcare providers about the areas where we deliver care and the transformation which is required to deliver that care in the time of COVID-19, there are several facets we need to consider. First is the support of the extension of our existing care areas. This could be as simple as repurposing the capabilities within the existing facility, and a specific example would be utilizing perioperative care areas to now support COVID-19 ICU beds. The second element involves expanding care areas to new facilities, including tents, hotels, dorms, and other areas capable of supporting patient beds and healthcare delivery beyond what we consider the traditional four walls of the hospital. While this involves physical locales, the change in healthcare delivery to support increased patient volumes and acuity also can impact how clinicians deliver care and the workflows of that care delivery. So healthcare facilities have been working to reduce non-COVID-19 patient volumes, which may include efforts such as canceling non-urgent surgeries or procedures. This activity in cancellations and repurposing care areas also allows us for an opportunity to look at different ways to support our system needs regarding COVID-19 patient treatments. Donya, given our previous information about how healthcare systems are extending and expanding to accommodate anticipated patient volume changes, I'm interested in your perspective on how we can utilize existing technology resources for medication management to support this endeavor.
Thank you, Kelly. While it's incredible to see these non-traditional care settings being deployed, they each bring their own set of logistical and operational challenges. And because med management is one of the most regulated and complex processes in healthcare, the question of how do I rapidly set up new care units becomes a critical path to surge clinical operations. Interestingly, Where standardization has been a hallmark of clinical and operational initiatives over the years, that goal may be an elusive target in these settings. However, there are some common principles that can help simplify and speed up rapid expansions while maintaining safe operations. The first principle is work with what you have. In the context of medication management technology, take an inventory of all equipment as early as possible, including locations and relative utilization of the automation. When possible, use existing supplies you have on hand, including any and all equipment you may have in storage in administrative areas such as education and simulation labs, and relocating them from low utilization to surge care areas. Even if the existing equipment isn't ideal in configuration, because it's already set up, relocation can happen rapidly. The second option is to acquire new devices. In some scenarios, especially when a location has a full census already, relocating equipment is off the table and new units must be obtained. Contact the automation vendor as early as possible to plan for surge expansions quickly. Finally, regardless of physical location, using the IT infrastructure of the sponsoring health system for all automation deployment. That includes any servers, software instances, and other IT setups to minimize any site-specific configuration of the equipment. Taking the use what you have principle, we can go even further. Not only can equipment such as servers, machines, and pumps be extended to these areas, but electronic medical records and medication management settings can be extended to surge locations as well. For example, if an off-site surge area will be a COVID medicine unit housing convalescent patients, consider copying ADC inventory and settings from a medicine unit in the hospital and add COVID-specific medications in higher quantities as needed. Ideally, these areas should be touched no more than once a day for refills, which highlights another key principle of back to basics. Critically assess what is really needed in a surge area versus what is more of an ideal state, possibly more of a nice to have for medication management. Kelly, in terms of nursing practice, what other considerations should we keep in mind?
Well, we're seeing that many COVID-19 care protocols are requiring the administration of IV medications. How we manage our administration and also the titrations of those IV medications is changing to accommodate safety of patients and clinicians and the preservation of critical PPE supplies. Many care delivery areas are actually adopting processes where the IV pumps, which were traditionally kept inside the rooms near the patient, are now being kept outside of the patient's room to address such factors. So in doing so, there are considerations we need to examine in terms of best practice for IV medication administration, and these include the rate accuracy for IV fluids and syringe medication administration in these circumstances, line management and how we're priming the tubing for the extension sets in these circumstances. And then finally, what we're doing for secondary infusions. These are a few things we need to consider as we continue to support IV medication administration in the time of COVID-19. Perry, can you tee us up to shift our discussion on efforts to mitigate infection?
Thanks, Donia and Kelly, for sharing those key operational principles. In looking at practice considerations, especially in the area of infection and cross-contamination, these new practice considerations are key for both nursing and for pharmacy. Donia, would you describe several of those key practice considerations for pharmacy?
Certainly. Thank you, Perry. We've covered several rapid deployment guiding principles. But foundational and perhaps one of the most important issues is protecting our clinical staff, especially minimizing their exposure to high-risk areas and keeping them safe. Examples of how to do this include considering using telepharmacy services such as remote order verification to limit clinical pharmacy staff on the floors and in the facility. Decreasing the number of med pass times for nurses by grouping medication administration times to the least number feasible per day for patients. Minimizing pharmacy tech exposure by creating COVID versus non-COVID zones in the hospital or surge area, with dedicated staff per shift servicing each area. On that note, some additional considerations on the safety of pharmacy staff, especially when dealing with COVID dedicated areas, include there's going to be a need to adjust inventory and quantities of fast-moving therapies in these areas to minimize the number of trips to ADCs where possible. Cleaning and more cleaning has become our new norm. Ensure that equipment is cleaned more frequently, including high-touch areas both outside and inside ADCs and cabinets. Finally, implementing more stringent hand hygiene will likely be needed. Use recommendations from federal and professional organizations such as the CDC and ISMP, coupled with hospital infection control, to develop appropriate protocols for COVID medication areas. Kelly, what are some considerations that nursing practice must be mindful of?
Well, Joanna, we're fortunate enough to have many professional organizations and associations issuing guidance right now and best practice recommendations as our care delivery workflows in nursing pivot to support emerging COVID-19 patient care needs. For instance, ECRI has provided infection control recommendations for medical equipment that includes dedicating medical equipment to confirmed COVID-19 patient care areas and or units, and practices of equipment cleaning, like you mentioned, for non-dedicated equipment. In looking how to optimize and conserve IV tubing set resources, both the Center for Disease Control and the Infusion Nurses Society have issued guidances as well for tubing change considerations in the time of COVID-19 patient care. In considering how we manage workflows with retrieving and dispensing medications, it may be beneficial for us to consider capabilities that allow nurses to maximize their time spent outside of patients' rooms by leveraging remote medication selection or queuing workflows available through web-based applications. These same capabilities can be used to document and witness narcotic waste processes, minimizing nursing trips to the ADC cabinet hardware for medications, and acting to optimize time spent on the actual medication administration and waste activity process. Finally, processes and procedures for individual use medications like inhalers or ointments must also be examined during this time. We encourage nursing and pharmacy leaders to collaborate together to determine what processes are most beneficial in your care areas to ensure availability of medication and also addressing the needs for clinician and patient safety. Perry, why don't we shift gears a bit and talk a little bit about some other resource considerations worth discussing for COVID-19 patient care and medication management.
Thanks, Kelly. We have discussed several key areas for practice consideration, operational practices, and keeping in mind that one of our key healthcare resources is people. Donia, would you speak to some key considerations associated with our people, healthcare workers?
Thank you, Perry. In this time of unique crisis, we're seeing clinicians across the country needing to provide as much remote access as possible, even for functions that were traditionally done in person. Managing ADCs is one of those examples. Activities such as adding temporary users should all be done remotely as the technology allows. As an example of this, The BD Pyxis Remote Assist functionality allows pharmacy staff to log into specific stations to help troubleshoot issues as the nurse is seeing them and to immediately resolve them. The added benefit here is that all such remote activities can also support multiple locations, including surge facilities, further minimizing the need to expose staff to high-risk areas. User permissions has also become a complex issue in and of itself. With temporary practice scope expansions and state licensure requirements changes comes a need to assess your automation security access policies and create a plan to grant access to staff that may be coming to work from other states. Kelly, this opens up a lot of new issues we've not had to deal with before. What are some that we need to consider here?
I think continuing along the framework that Perry set us up for in this portion of the discussion is staff augmentation. We know that healthcare facilities are heavily augmenting their staff with temporary clinicians from other care areas now working in the ICU or med-surg areas supporting COVID-19 patients, or even volunteer clinician corps that are being used by some states. All of these clinicians who are new to these care areas will need access to the medication management system as users in these care areas. By assigning user profile information in these areas, access to medication management systems can quickly and reliably be provided in a standardized manner. Additionally, I would say that user profile permissions for medication management may need to be adjusted to support expanded or downgraded medication access capabilities in support of staffing augmentation. For example, charge nurses may now be assigned additional floors to support, or a CRNA is now functioning in the role of an ICU nurse and needs permissions based on those capabilities and responsibilities.
Thank you, Donia and Kelly, for walking us through the scarce resources of our healthcare colleagues. We looked at today several different areas of practice and operational. We even listed out references from ECRI and ISMP and other professional areas. When we think, Kelly, about other resources that come to mind, would you list some key references for COVID-19?
Yeah, as the spread of coronavirus continues throughout communities, we want you to know that we are here to support you with access to and support for our products. BD has made available a website to provide answers to your COVID-19 related questions. And there are a number of clinical associations, like you mentioned, Perry, and we've mentioned throughout the presentation, that are providing updated information specific to the pandemic, clinical care delivery, and practice modifications that are also listed on this slide and available to the public.
Thank you, Kelly and Donia, for offering your expertise in assisting the attendees. On behalf of Kelly, Donia, and all of the BD associates, thanks for each attendee's time, and more importantly, your expertise in caring for your patients. Thank you. Here you go, Whitney.